we're going to proceed with the next talk. So it is my great pleasure to welcome Richard Frank. He is the Margaret T. Morris Professor of Health Economics at Harvard University, a renowned scholar with a long history of service in healthcare and health policy, most recently as the Assistant Secretary for Planning and Evaluation at HHS. And he's also someone that's been a mentor to just many students, young faculty, the sort of person that has always looked out for people and been constructive and supportive. So it is my great pleasure to welcome Richard Frank.
Thanks. I'm really pleased to be here. And in the interest of full disclosure, I want to start off by saying that I'm not a health IT guy. And in fact, I am going to spend the next 20 minutes or so demonstrating that to you. But I do come to these issues, and during my time in the government, we dealt with quite a few HIT-related issues from a policy perspective. And so the hat I'm going to be I'm going to be wearing two hats as I talk to you. One is that of an academic health economist interested generally in markets and health policy. The other is as a person who's been involved in policy making and sort of trying to figure out how do you sort of make the world safe for HIT and make HIT safe for the world. So for that reason, I'm going to focus on the role of HIT in making delivery system US-style reform work. And I'm going to talk a little bit about how regulated competition can make HIT potentially work better. And when I use the term HIT, I mostly mean electronic health records and health information exchange and interoperability that allows data to flow through the healthcare delivery system. I want to focus on what I might broadly characterize as regulated competition. That is, issues related to the role of that HIT can play in making healthcare markets work, or at least work better, and how market arrangements affect how HIT is evolving and potentially could evolve. So let me start by setting the policy context. So the policy context is one where the de facto US healthcare system is moving towards what one might call regulated competition, where a variety of organizations operating under budgets or quasi-budgets compete. And these organizations include health plans, ACOs, networks of contractually linked providers, integrated delivery systems, and hospitals and agglomerations of providers competing for things like bundles and things like that. Now, regulated competition is being used in health insurance markets that involve public programs, such as the health insurance marketplaces or the exchanges under the Affordable Care Act, Medicare Advantage, and Medicaid managed care organizations, which are now roughly 67 to 70% of the Medicaid world. ACOs are obviously another example, and then the increasing number of bundles that are out there are a focus of what I would call regulated competition. Now, in regulated competition, more emphasis is being placed on the management of care and quality outcomes. The market outcomes that we're seeing in the health insurance exchanges or marketplaces are revealing that organizations that have figured out how to manage care and pay attention to quality outcomes are making money. And the ones who are more traditionally linked to sort of employer-based health insurance arrangements where underwriting is the name of the game, are losing money and are sort of starting to fall by the wayside. And I think we're going to continue to see that kind of evolution in the marketplaces, where more Medicaid MCO organizations are going to branch into the health insurance marketplaces, and some of the traditional employer-sponsored plans are going to sort of play a lesser role, or they're going to start to adapt quickly. Now, these providers compete in part by having tightly managed networks, and this is true both in the MCO and the marketplaces. And the Medicare Advantage world continues to evolve, and you see narrow networks and tightly managed networks being a more prominent thing in the Medicare Advantage program. The ACO model is still young, but the long-term vision of it is of a budgeted, is a series of budgeted competing systems that really sort of focus on quality and cost. In each case, the healthcare system is being asked to take more of a population health orientation, to improve quality, to reduce waste, and to empower consumers to make choices that meet their needs and circumstances. For Medicare Advantage plans, for Medicaid MCOs, and health plans in the marketplace, they face relatively high-powered incentives to do so. Mostly on the financial side, but increasingly on the quality side. So what that requires is enhanced quality. In order to make this work, what that requires is enhancing quality measurement, greater accountability, improved risk adjustment, and more robust decision supports for consumers. Okay? So those are the pieces of the puzzle that the policy world is now demanding on us. In the case of ACOs and other systems of care, my own view is they need to move further in the direction that we've seen in the more sort of plan-oriented parts of the system. That is, they need to take on more high-powered financial incentives. And this is not just my view, but also shared by organizations such as MedPAC and a variety of private analysts. So in addition, we need to continue to bolster the quality side of ACOs if we're going to give them more high-powered incentives. And when I talk about high-powered incentives, I'm mostly talking about two-sided incentives. Right now, the majority of ACOs have one-sided risk sharing, and I think that we'll make much better progress and have more robust competition if there's two-sided risk sharing. Now, for many providers, there remains a tremendous amount of fee-for-service still out there. But I think change is coming, and change is coming because the large public insurance programs are starting to flow down different types of payment incentives in new ways. At the same time, we see a variety of non-competitive impulses sort of coming to the market. Hospital mergers, increases in vertical integration, in particular between hospitals and physician practices, are troubling. And we're also, alongside that, seeing record margins in the hospital industry. So if you go back historically to the 80s and 90s, you'll see that hospital margins have never been as high as they are right now. Okay? In technical terms, in economics, we call that fat and happy. So let me turn to regulated competition and the role of HIT. Regulated competition will be enhanced through the flow of information that EHRs and interoperability promise. And that's an assertion right now, and I'll back it up. Specifically, what I'm talking about there is having access to more complete information on individuals' medical conditions and their socioeconomic status than claims data tends to offer is key to improved risk adjustment for plans and for hospitals. So as you know, in things like the Medicare rehospitalization program, we sort of sting and bonus plans based on their readmissions performance. Well, there's evidence suggesting that socioeconomic status matters there, and that's true in a variety of other areas. And so we need to get information, and it can't just be, are you a dual or not, which is sort of kind of the way we do it now. Second, creating information so that care can be coordinated and improved has been always the thing that everybody's hoped for. And if you're going to do that and realize the outcomes that's promised, you really do need that kind of information flow, and it has to be built on a platform that's not just a reimbursement and claims-based platform. Then providing consumers with predictive analytics that will allow them to make choices about expected costs, expected outcomes, when they're deciding what plans to enroll in, what providers to choose, and what courses of treatment to decide upon with their providers. You need that kind of information flowing through the system. You need to agglomerate it, and you need to sort of produce user-friendly versions of the analytics for consumers. And then finally, I think that building measures of quality that use more than that use more information that relates directly to outcomes is central to more robust competition and more fair competition in terms of a world where everybody's operating with high-powered incentives. So health information exchange has, I think, the additional pro-competitive feature that it can, if done right, promote the entry by virtual groups. And I think that in a lot of places, virtual groups are going to be a key element for creating new competition and new entry in the market. So together, I think these factors lead me to believe that the performance of regulated competition will be substantially improved by widespread interoperability. Okay, so that sort of lays out a little bit about the role of HIT in helping markets work better. Now I want to turn it the other way and say, how do we get a market that makes HIT and interoperability work well? Now, the implementation of interoperable HIT is taking place in a market context. Recent reports from the Office of National Coordinator and also in the trade literature raise some concerns about market failures related to the promotion of interoperability. That is, there's a lot of disappointment out there with the degree to which health information exchange is actually occurring. And out of this observation has come propositions and accusations around a set of practices that are now kind of termed information blocking. And a few sources of these market failures have been identified. The first two are kind of very simple ideas about the exercise of market power, much as we see in other parts of the healthcare system and in other areas. The third is also been widely discussed, but is a sort of twist on a sort of long-standing principle in economics. So let me just mention them, what they are. The first is healthcare providers may balk at interoperability in order to retain patients, in effect making their demand curves less elastic. That's, in a way, the way they retain market power. This is especially the case for hospitals and hospital systems, vertical and horizontal, that operate in oligopolistic markets. Now, this is not a settled issue. There was a new paper out this week that is arguing that hospitals operating in more competitive markets are more likely to adopt agglomerate into compatible IT systems. There is evidence going the other way as well. And so I think this is a very important one to kind of get a good bead on. And the econometrics and the modeling here are messy. And so that's probably why immediately you're getting, well, there's also the incentives for publication, but I'll leave those aside. But in fact, honestly speaking, how you model this is probably going to matter a lot. Second, HIT vendors may resist interoperability in order to preserve their market power that comes from having significant product switching costs and less portable data. Again, this allows them to price for a variety of things that might not other be priced for and differentiate themselves in certain ways. Now, the third source of market failure has been referred to as the anti-commons problem. So if, how many of you are economists? Or, okay, how many of you know economists? There you go. Okay. Well, in basic economics, what you learn is about the overgrazing problem, right? So that if you have a field and you have communally owned cattle, people tend to overgraze the land because nobody has an incentive to preserve the land. And so what you'd like to do is establish a set of property rights, which is give people private land and put fences up, and then you don't overgraze. So that's the what's known as the problem of the commons in economics. This is the problem of the anti-commons in HIT, which is that you have network benefits in HIT, and the consequence of that is the more people use a compatible platform, the higher the benefits are. And so in the case of HIT, in a sense, the optimal participation rate in a common platform is 100%, okay? And so the problem that occurs here is that there are benefits from being able to exclude others because you can try to exercise power by charging for access or by differentiating yourself because you have unique or somewhat exclusive rights to that platform. And so this is sort of the flip side of the problems of the common. So what are the policies? So 3 problems. What are the policy responses to this? The first one is one that has been made by Karen DeSalvo and a variety of other people, argues that as we shift from paying for volume, fee for service, to paying for value, some kind of performance-based incentive payment, providers will have a stronger incentive to produce high quality efficiently, and this requires coordination, elimination of duplication, and outcome tracking, among other things, okay? And this, in turn, is facilitated by health information exchange, and because of that, providers are going to increasingly demand that the HIT vendor market offers them products that facilitate health information exchange. Okay? Now, the success of this approach, so the logic is okay, but it turns entirely on to what extent the quality measures that you're paying on in this sort of new value-based system are sort of dependent on health information exchange. So for example, if I were to pay on do you get an aspirin after a heart attack, you don't need health information exchange for that, right? That happens in the hospital, boom. And so if you don't pay on things that are strongly facilitated, and because you can only pay on a handful of measures, you have to be very careful in what you select. And right now, I would not argue that our system is overly weighted towards outcome measures that fully require health information exchange. So what I'm talking about, for example, is measures of, for example, flare-ups in asthma or COPD, where usually there are a variety of primary care and specialists involved, and if they're not talking to each other and people aren't making the right schedule of visits and things, things tend to unravel. Okay, so that's thing one. So the logic of relying on new payment systems is good if you've got the right outcome measures, and the right outcome measures have to be selected in terms of so that they have strong quality side incentives to engage in coordination and health information exchange. Second response is a more regulatory one. So for example, the new macro rule has a provision in it that says that providers have to attest that they are not willingly or knowingly taking action to limit compatibility and interoperability, okay? This is like the Boy Scout pledge, a little bit. And it's extraordinarily hard to enforce. Those of you who have been Boy Scouts know. Girl Scouts, probably the same thing. It's hard to enforce. Typically, it involves fairly burdensome due process, in fact, if you want to bring a complaint. And so it's likely to be a it's likely to be mostly a bully pulpit feature as opposed to a real actionable regulatory feature. The third response is to create governance for standard setting practices and policies aimed at health information exchange and interoperability. This approach directly addresses the anti-commons problem, or at least part of the anti-commons problem that I was just talking about. Standards make access to data easier across different systems and organizations, but there are trade-offs when you do that. So for example, and most of the trade-offs involve how do you structure institutionally the bodies that are going to do this. So on one hand, you can imagine a system where you have incumbents, larger incumbents, that dominate this. So now recall that the three-firm concentration ratio in the vendor community is about 50, 60% at this point. So you have a pretty concentrated market. And therefore, there are folks there who have an interest in protecting their market power, and there are some that are a lot richer than others that are operating in this market. So you could imagine a standard setting process that is dominated by a few major players that set standards that make things easier, but also lock in things that make their lives easier and preserve their market positions. On the other hand, you also have the potential for free riding on the part of the small guys who don't want to pay, don't want to get involved, and things like that. In addition, there is also the concern that if you set standards today that are kind of fairly rigid, that what you do is you lock in today's technology in a world that's changing very quickly. And we've seen that happen in a lot of places. Thank goodness we don't have VHS anymore instead of beta, but we have a long history in sort of standard setting in the United States over technology, where we lock in where we lock in sort of a set of practices and technologies that it winds up being very costly to get around as the technology evolves. But I think, ultimately, standards setting is a must, and I think a important research and analytic activity is trying to figure out what the right institutional design is. Now, unfortunately, this is not amenable to econometrics, but that's the bad news for everybody in this room. The good news for everybody in this room is on the sort of problem of the commons side, Eleanor Ostrom did a series of extraordinarily careful case studies of different ways of setting standards and things to solve the problem of the commons, and she got a Nobel Prize. So, there's room here for doing that kind of research. I also think, and I can't overemphasize this, that putting a lot of weight and a lot of financial incentives and selecting outcome measures that push the field towards coordination is going to be critical here. And the good news there is that there seems to be evidence that when greater coordination happens, CAP scores go up, a variety of fairly crude outcome measures seem to improve. And a lot of that comes out of some of the more recent ACO research. And so what's also heartening about this is that, in fact, organizations that tend to make greater use of health information technology and to be more engaged in information exchange tend to also produce more coordination and some evidence of better outcomes. So, again, this is not settled, but it's a little bit heartening that if we push on that front, we'll tend to drive the system to the right place. I think there's enormous misunderstanding and uncertainty about the net effects of delivery system reform on competition. In my view, health information exchange is a critical tool in making competition work in healthcare generally. And today, as you look at, for example, the creation of ACOs, there is no evidence, according to some recent research, that more ACOs lead to more consolidation in hospitals, for example. And so I think the important news is we're facing a world of a lot of consolidation anyway. I think by using health information exchange wisely and strategically, actually we can bolster competition and not harm it. So our job from here is to develop evidence on the extent of competitive threats, such as information blocking, to understand what the relationship between healthcare market structures and adoption of new technologies is, and then to design institutional arrangements and incentives that promote health information exchange and does so in a way that's flexible enough to allow for continued evolution of the technology. So I'll stop there and take some questions.
Thank you. I've heard some really compelling, over the years, some very compelling anecdotes about information blocking. What I'm a little unclear on, and that doesn't make a widespread phenomena, but what is the information that hospitals really want to keep secret? Like, is it about their learning of the cost of a patient population that would lead to better bargaining with insurers? Is it about patients perceive that if they had that information, there'd be a quality differential? Do you have any thoughts on what that would be?
Yeah, I mean, so I'll give one anecdote deserves another anecdote, and then after that we'll have data. Anyway, I think one of the concerns is that you say to a patient says, well, I'm thinking, Cousin Louis told me that I really ought to go see the cardiologist at Beth Israel Medical Center instead of the Brigham and Women's in Boston. And the reaction very often is, well, I'm going to have to, they're not going to know your medical records. I'm going to have to do this. I can set you up with, Harry down the hall here, and he'll have everything there. Why don't you go to him? And I think the concern is that if it's easy to go there, then it's hard to get in the way of people going out of the system. And this is and so here's the downside of the ACO, is that we're creating a bunch of incentives out there right now where prevention of leakage is a key part of the business model. And so there are incentives to do that in some of these systems. And so in a sense, this is why the anti-commons problem, it's a version of the anti-commons problem, how you implement the anti-commons problem.
look at the healthcare system in the United States, I think the other very similar system is our education system. And the underlying denominator in both of these systems is that the customers, patients or students or their families, really cannot make informed decisions. To what extent do you think the problems that we have with our healthcare system, and in particular with interoperability, could be addressed if patients were brought into the center and were given choices to make?
Well, I think that's the idea, and if I'm getting your question right, in a sense, what I think you mean is how do we make sure that patients are empowered, right? And I think that that's why information is important. But I think giving people raw information is not going to be helpful. In fact, there's a lot of evidence out there suggesting that information overload is a real thing. And when people get overloaded with information, you're giving market power to their existing providers. So I think what you want to do is make information really convenient. So, for example, an app. And somebody says, okay, I've got breast cancer, and it's this type of breast cancer, and I have a choice of these people at the Brigham, these people at the Mass General, these people at the Leahy Clinic, and here's where I live. What's going to work best for me, according to, 2 or 3 key variables, and it'll sort of spit out a bunch of rank ordering of things. And I think that kind of thing make things okay. I mean, for example, the star ratings in Medicare are actually we're seeing people start to move away from the 3-star rating things up towards the 4. And so I think that if you make things simple and sort of rank order things, you can sort of start to nudge people towards more efficient outcomes. But you need big analytics and you need flow of data together.
So one of the areas where information around healthcare is particularly opaque is around behavioral health. And I know, Richard, you've done a lot with the Parity Task Force and so forth. And I'm wondering if you could comment. It's almost like a different sort of information blocking, if you will. But given the fact that it's the most costly healthcare category currently by some measures, Health Affairs recently said it was the top above cardiac. Do you have any recommendations for addressing that, particularly how it affects, confidentiality?
Yeah. So, unfortunately, here you've struck on something that I know too much about, as opposed to HIT where I know nothing. But anyway, first of all, just a cocktail fact on the cost thing. In 1970, we spent 1% of GDP on mental health. Anybody want to guess what we're spending in 2015? 1%. Okay? We don't have a cost problem in mental health. I mean, it's costly in that people who have mental disorders also have lots of other problems. But it's not clear that that's because of their mental illness. That's because of a lot of other things. So, but the actual mental health stuff hasn't. First thing on the sort of coordination of care there, and I agree with you that implicit in your question is here's an area where we really can probably have some gains from coordination of care. I agree with that. One of the problems is that behavioral health providers were excluded from the meaningful use subsidy program. And I understand why. You have to start someplace, and doctors and hospitals seem to be a reasonable place to start. But in fact, as we go forward and demand more coordination, that's going to be a problem. So I think that's a really important thing, is that they in particular need investment. And if you look at the rates of HIT use in the behavioral health sector, it's really, really low. Yeah. Psychiatric hospitals, even large clinics, very little of that. So I think it's important. So that would be one step that would be important to do. I think the other thing, though, on the optimistic side, is we are creating enormous incentives to mainstream behavioral health. Integration, pushing it into the healthcare system, pushing it into HCOs and the like, and making even specialty providers part of these larger systems. And that's because, in part, parity and other things have mainstreamed behavioral health in a variety of other ways. And so I think that is naturally going to sort of cause them to be folded into these other systems. And because by doing a better job of, for example, making sure that somebody who's got diabetes and depression get their depression taken care of, it actually helps their diabetes, and that'll be the kind of thing that people will figure out is in their interest in these new high-powered payment systems. But actually, diabetes and depression would be a great outcome measure, right? Sort of take the people with depression and diabetes and see how they do. That would be a great one, because that's one where you really need to coordinate care. Did I miss any part of your question? Other part?
I think you addressed it fairly well, particularly the fact that, for a long time, of course, even now, the majority of people with mental health conditions are mostly mild and moderate conditions that are managed by the primary care providers. But this last comment that you said about the measure, I mean, there exists a diabetes and depression quality measure that nobody uses.
Yep.
So we really have we don't have a lot of good quality measures in mental health.
Yeah, no, well, yeah, this is a classic case of somebody says that in a meeting at CMS, and the answer is, well, we shouldn't do anything. And I argue vociferously that using a flawed measure of something that's important to try to measure is way better than not measuring at all. So there you go.
I'd like to hear your comments on what I see as one of the impediments to health information exchange, and that's the absence of a national patient identifier within the U.S. healthcare system. Can you give us any insights into when that might happen?
No.
All right.
But I agree that would be a desirable thing. Although, I have seen some recent evidence showing that our ability to match has just improved a great deal even without. But I agree with you that it would be desirable to do something like that. Oh, I know what it was. Confidentiality. That's where your two comments come together. I think that I understand the stigma of mental illness and addiction, and I understand the concerns about that and employment. I think the pendulum swung way too far, to the point where we made the trade-off in terms of being 100% sure on the confidentiality and putting up huge roadblocks to managing care in a coordinated, thoughtful way. And I just think that we need to swing it back. And I think that HIPAA mostly does a really decent job here, and I think sort of HIPAA should be the foundation of this and not all these other layers of stuff. And not to say that we shouldn't be vigilant, but that I think that HIPAA should be the heart of where we stand on confidentiality there. Okay.
What a thought-provoking and interesting session. A lot to think about. At this time, let's take a 10-minute break, and then we'll start the next research session, which will be healthcare quality information. I'll ask the panelists for the next session to come forward.